This is Chapter 11 of Wilkins. We're going to discuss vital signs. We discussed this just a little bit in class. The chapter outline is in your textbook, so we're going to talk about temperature, pulse, respiration, blood pressure, documentation. Always documentation. So the determination of 4 vital signs, body temperature, pulse, respiration rates, and blood pressure, is considered standard procedure in patient care. There used to be a 5th vital sign, and that was smoking. And smoking was taken out as the 5th vital sign in this 12th edition of Wilkins. In the previous hundreds of editions, actually many other editions, they always included smoking. So for some reason, it was taken out. So we've got body temperature, pulse, respiration, and blood pressure are the standard procedures in patient care for vital signs. So patient preparation, you're going to have the patient seated upright at eye level for instruction. You explain the vital signs and obtain their consent, otherwise it is considered battery. You explain how vital signs can affect dental hygiene and dental treatments. A lot of times they're kind of shocked. Oh, I'm just getting my teeth cleaned. Why are you taking my blood pressure? And so you explain why, that you're using it as a screening device. You do it for all patients. They're not being singled out for any reason. And that you use it as a way to educate the patient. And during the process, you explain each step as needed. Most patients, aside from little children, have had their blood pressure taken before, so the explanation can be very simple. But for your dental hygiene care planning, reporting vital signs contributes to the proper systemic evaluation of a patient in conjunction with the complete medical history. So dental hygiene care planning and appointment sequencing are directly influenced by your findings. Can the patient tolerate a morning appointment, an afternoon appointment, an all-day appointment? Do they need shorter appointments? When vital signs are not within normal limits, you need to advise the patient to check with their physician. Sometimes you don't even get to treat the patient. They are dismissed if things are that out of the norm. And referral for medical evaluation and treatment is oftentimes indicated. So look on the box 11.1 for your keywords that are related to vital signs. You might be seeing them again. All right, body temperature. Temperature isn't one of those things that we routinely take in the dental office, but while preparing the patient history and making the extraoral and intraoral examinations, the need for taking the temperature may become apparent. You're feeling around the head and neck area, and you might find that they feel very warm. Or the dentist may have requested that the procedure of a temperature be taken in conjunction with their current oral disease. If they come in with something called necrotizing ulcerative gingivitis, the doctor will want to know, do they have a fever? Because that might be the determining factor whether that particular patient requires an antibiotic to reduce infection or not. So the indications for taking temperature include new patients, just as a baseline, for a complete examination during the maintenance appointment, when oral infection is known to be present, for example, that necrotizing ulcerative gingivitis or periodontitis, sometimes fever is associated with that, apical or periodontal abscesses, acute pericoronitis, if they have an infection around a partially erupted lower mandibular wisdom tooth, and along with other vital signs prior to the administration of local anesthesia. And at any appointment when the patient reports illness or if they are suspected of infection. It's the protection of the health of the healthcare personnel, you and the patient or the families also who may be exposed secondarily to having somebody that is actively sick in the office. So special significance during epidemics when community exposure are at risk is really important. We don't want sick patients coming into our offices and spreading aerosols. Now what we prefer and what the dentist prefers, because it's their schedule and their income, are sometimes two different things. But you might need to take a temperature also for a patient's referral for medical care when it's indicated. But the maintenance of body temperature for adults, you need to know these ranges. The normal average temperature is 37 degrees Celsius. That's your 98.6 degrees Fahrenheit. And the normal range is from 35.5 to 37.5 Celsius. And that translates to 96 degrees to 99.5. That's the normal range. So if somebody's normally running hot at 99, it doesn't mean that they have a temperature. So you want to ask the patient, do you know what your normal is? For older adults over 70 years of age, the average temperature is slightly lower. For children, there's no appreciable difference between boys and girls. The average temperatures are for first year of life, 37.3 degrees Celsius, and this is all in your book, or 99.1 degrees Fahrenheit. Fourth year, 37.5, about the same, 99.4 degrees Fahrenheit. Fifth year, 37, or 98.6. 12th year, 98. Okay, and temperature variation. Now, you need to know some terms. Pyrexia, okay, that's fever. And a fever is, or pyrexia is a value over 37.5 or 99.5 and above, over that. Hyperthermia, values over 41 degrees Celsius, that's 105.8 degrees Fahrenheit. That is a high temperature. And hypothermia, values below 35.5, and that's 96 degrees Fahrenheit. Factors that alter the body temperature could be the time of day. It's highest in late afternoon and early evening, and lowest during sleep and early morning. Temporary increases of temperature can be during exercise, drinking hot fluids, smoking, or the application of external heat. Pathological states, infection, dehydration, hyperthyroidism, myocardial infarctions, that's a heart attack, or tissue injury from trauma can increase blood pressure. I'm sorry, temperature. I'm talking temperature. Woo. Decreasing temperature can be starvation, hemorrhaging, you're losing blood, as well as physiological shock. Methods for determining temperature. The location of the measurement, you can have oral. It's the most common site due to the ease of access. But drinking hot or cold liquids just prior to taking the temperature is going to affect what the thermometer says, so it's advised that you wait at least 15 minutes before you take an oral measurement. It's not recommended for infants, young children, the unconscious, patients that have behavioral issues. You don't want them biting and breaking the thermometer. Temporal artery, which is your forehead, those measurements are taken with an electronic device. I think they are way cool. They're easily tolerated, and the results are comparable to the oral thermometers. They have ear devices with a tympanic device. Medical or hospital applications can use the axilla or rectum for assessment. And there are different types of thermometers. There are electronic thermometers, and they are covered with disposable protective sheaths. They go under the tongue. Let me see if I got a picture. Yeah, they go under the tongue. They give a digital readout. There are tympanic thermometers, and they are, again, covered with a protective sheath, and they're inserted gently into the ear canal. After short exposure, 2 to 5 seconds, you'll hear a beep, and that will record on the device what the temperature is. And there are disposable paper or chemical thermometers. And those are chemically treated for oral or axillary use. They've got raised dots that change color to reflect the temperature. And they are single use and ideal when infection control is a concern. There are temporal artery thermometers. And those measure the temperature of the skin over the temporal artery of the head. You place the scanner on the center of the forehead, midway between the eyebrow and the hairline, and then you slide the thermometer across the forehead until the hairline is reached. And that's what the picture of that little boy is. You replace the protective cap after the temperature is taken. The old thermometers had mercury in glass. The blue tip was the oral, and the red tip was the rectal. And they're no longer used because of the risk of mercury exposure. My mother was a nurse for almost 50 years, and those old mercury thermometers are still around in linen closets throughout the country. One mercury thermometer broke in Maryland, and it closed down the entire middle school with the amount of mercury that was spilled. And we're talking a minuscule amount of mercury in these thermometers, but it's taken seriously these days. So patients that come in with a high temperature of fever, pyrexia, of 41 degrees Celsius or 105.8, you treat them as a medical emergency. They are not there for elective services, and I can tell you they're not feeling so good. They need to be transported to a hospital. 105 is an extremely dangerously high temperature, and seizures could result, as well as brain damage. You want to check for temporary or factitious causes. Make sure, factitious, did they do something to themselves? Did you just drink a pot of coffee? Did you just smoke? Okay, sometimes you have to wait that 15 minutes and repeat it. Review the medical dental history and postpone elective oral care. Okay? Let's go on to pulse. And the pulse is the intermittent throbbing sensation felt when the fingers are pressed against an artery. It's the result of the alternate expansion and contraction of the artery as a wave of blood is forced out of the heart. The pulse or heart rate is the count of the heartbeats. And irregularities of strength, rhythm, and quality of the pulse are noted while counting the pulse rate. And we have a template for you to fill out when you're taking your vital signs in both of our, at GCC as well as MEC, that not only are you going to write the pulse down, but you are going to write your qualifiers. It's going to have word prompts for you, and you're not just giving a number. You are qualifying. Is it shallow? Is it strong? Is it irregular? Is it steady? And the book, Your Wilkins, has a lot of good terms for you to be able to use, as well as in the clinic help portion of Blackboard. What are the normal pulse rates for adults? There's no absolute normal. The range can be anywhere from 60 to 100 BPMs, beats per minute. Slightly higher for women than men. The more aerobic the person is, the lower the pulse rate. So a runner might have a pulse rate of 60 versus a non-runner might have a pulse rate of 88. They're both considered normal. But a runner is more cardiac, has a better cardiac fitness level. Children, the pulse rate or heart rate falls steadily during childhood, so it starts out a little bit high and then decreases. Factors that influence pulse rate, and then usually fast pulse rate, then that's over 100 beats per minute in an adult, is called tachycardia, T-A-C-H-Y, tachycardia. An unusually slow heartbeat below 50 beats per minute is called bradycardia, and you need to know those terms. Increased pulse can be caused by exercise, stimulants, eating strong emotions, extremes of heat as well as cold, and some forms of heart disease. Things that can decrease your pulse, think about when you're sleeping, okay? It's caused by sleep, depressants, fasting will slow your pulse rate, quiet emotions, as well as low vitality from prolonged illness. There are emergency situations, so take a look at your textbook for those. The procedure for determining the pulse rate. All right, for the sites, the pulse can be felt in several points over the body. We typically will feel for the radial pulse, which is at the wrist. Other sites convenient for the use in a dental office or clinic could be the temporal artery on the side of the head in front of the ear, or the facial artery at the border of the mandible, the carotid artery, which you know is used during CPR, the brachial pulse, and we use that as used for the infant. So, we're going to tell the patient what's going to be done. We're going to be taking your vital signs, and you have the patient in a comfortable position with the arm and hand supported, palm down. You locate the radial pulse on the thumb side of the wrist with the tips of your first 3 fingers. Okay, you don't want to use your thumb again because that has a pulse, and you can confuse your pulse with the patient's pulse. So, you're going to feel the pulse. When the pulse is felt, you exert light pressure and count for 1 clocked minute. Right? You're not doing it for a half a minute and timesing it by 2. You're not doing it for 15 seconds and timesing it by 4. You're doing it for a full minute because you want to feel for any irregularities as well. You want regular rhythm. All right? And sometimes it's regularly irregular, and irregularly irregular. And you need that minute to really feel that. You're going to talk about rhythm, volume, and strength. Is it full, strong, poor, weak, thready? You record the date and pulse rate as BPM with other characteristics on the patient's record. So a pulse rate over 100 is considered abnormal for adults and require further investigation. Sometimes they're just nervous as well. So this picture shows you the arteries of the arm, and you want to note where the radial pulse is as well as the brachial pulse because you're going to be feeling both of those. Determination of the pulse rate. A is the correct position for the hands. B, the tips of the clinician's first 3 fingers are placed over the radial pulse. And you're not using your thumb. So respiration's always taken along with the pulse. And you're not telling the patient, you're taking the pulse, now I'm going to be looking at your respirations. You just keep your hand on the pulse, on their radial pulse, and you just continue to count. Oftentimes I'll tell my patients if they're staring at me, just close your eyes and relax. I'm going to be, feeling this be having my hand on you for 2 full minutes to make sure I have an accurate pulse rate, and that's all they need. But the function of respiration is to supply oxygen to the tissues and to eliminate the carbon dioxide. There are variations in normal respiration, such as rate, rhythm, depth, quality, and may be symptomatic of disease as well as emergency states. So for normal respirations, for adults, the adult range is anywhere from 12 to 20 per minute, slightly higher in women. For children, the respiration rate decreases slightly during childhood. Some of the factors that can influence respiration rate are the same factors that can influence pulse rate. So a rate below 12 per minute, bradypnea, B-R-A-D-Y-P-N-E-A, just like bradycardia, slow heart rate, bradypnea, slow breathing, slow respiration, is considered subnormal for an adult. Over 28, tachypnea, and rates over 60 are extremely rapid and dangerous. For increased respiration, that is often caused by work or exercise, excitement, nervousness, strong emotions, pain, hemorrhage, as well as shock. Decreased respiration can be caused by sleep, certain drugs and medications, as well as pulmonary insufficiency. So procedures for observing respirations, you want to make the count of respirations immediately after counting the pulse. Maintain your fingers over the radial pulse, and the respirations must be counted so the patient really isn't aware, because if they know you're counting their breaths, they're going to start changing how they breathe. So you count the number of times the chest rises in 1 clocked minute. Again, you're not making shortcuts for this. You are going to observe the depth, the rhythm, the quality, the sounds, and record that. The depth you describe as shallow, normal, or deep. Rhythm you describe as are they evenly spaced, or irregular, with pauses of irregular length between. The quality you describe as strong, easy, weak, labored, or noisy. The sounds describe deviant sounds made during inspiration when they're breathing in, as well as expiration, or both. Normally we don't hear anything. Sometimes you'll hear some wheezing. And the position of the patient. When the patient assumes an unusual position to secure comfort during breathing, or prefers to remain seated upright, you need to make sure that you mark the record accordingly, because they might have breathing issues if they don't want to lie down all the way. So one of the things that you would ask is, do you have to sleep propped with pillows? So blood pressure. The components of blood pressure. Blood pressure is the force exerted by the blood on the blood vessel walls. When the left ventricle of the heart contracts, blood is forced out of the aorta and travels through the large arteries to the smaller arteries, arterioles, and capillaries. The vessels of the heart, are shown in chapter 67 if you need to review that. Pulsations extend from the heart through the arteries and disappear in the arterioles. During the course of a cardiac cycle, the blood pressure is changing constantly. So we have a systolic pressure as well as a diastolic pressure. The systolic pressure is the peak or the highest pressure. It's caused by ventricular contraction, and the normal systolic pressure for an adult is less than 120 millimeters of mercury, less than 120. Diastolic pressure is the lowest pressure. It is the effect of ventricular relaxation. The normal diastolic pressure for adults is less than 80 millimeters of mercury. So 120 over 80 used to be what we considered a normal range. Notice how I'm saying it's less than that now. Now at 120 over 80, it is considered to be pre-hypertensive. There's pulse pressure, and that's the pulse pressure is the difference between the systolic and diastolic pressure. Factors that influence blood pressure. You've got the blood pressure depends on the force of the heartbeat, peripheral resistance, the condition of the arteries, the changes in elasticity of the vessels that can occur with age and disease. Also depends on the volume of blood in the circulatory system. Factors that increase blood pressure can be exercise, eating, stimulants, emotional disturbance. The use of oral contraceptives can increase blood pressure. Also, blood pressure tends to increase with age, as well as the length of use of oral contraceptives. So when we have a patient taking oral contraceptives, we do put them as an ASA2 because there could be blood pressure related issues. Factors that decrease blood pressure: fasting, rest, depressants, quiet emotions. Similar to heart rate. The equipment for blood pressure, you need a sphygmomanometer, and that's made up of a pressure measuring device, which is the manometer, and an inflatable cuff to wrap around the arm and under certain circumstances the leg. You have a mercury sphygmomanometer, which is an analog, and that's the traditional system, but mercury with its potential health hazard and mercury spillage is less commonly used today, and it's shown to be more accurate, though, and consistent than other types. So that's the mercury analog. Then you have your aneroid sphygmomanometer, which is an analog, and that's compact, portable, glass-enclosed gauge with a needle for registration of the blood pressure, and it requires regular calibration to keep accurate. There are electronic or digital sphygmomanometers, and those are automatic determination of blood pressure without the use of a stethoscope. And also you need to choose the right size cuff, and that's critical for taking blood pressure. So the cuff should be long enough to encircle 80% of the arm and wide enough to encircle 40% of the arm at its midpoint. A longer, wider cuff is required for larger arms. Now, the wrist or finger devices in the automatic cuffs are considered to be less accurate and are not considered for professional use. So we don't allow wrist cuffs in the clinic. You need a stethoscope with the type of blood pressures that we're taking, and that consists of a diaphragm or cupped end piece that transmits and sends sound through the tubes to the earpieces. It's used with mercury or aneroid type analog sphygmomanometers. So what's the procedure? You're going to prepare the patient. All right, this is telling you the sizes of the cuff, and the nice thing with the cuffs that we have at the MEC, we have a standard adult. It tells you where to put things, so it tells you where to put these hoses, okay, as well as it tells you when you're wrapping the cuff around the patient, it tells you when you need a larger cuff. So it's got those markings on it, just as a guide. So you're going to tell the patient briefly what you're going to be doing. We're taking a blood pressure. We do this on every patient. We'll be doing this each and every appointment. We are doing it as a screening service for you. Detailed explanations can be avoided. You seat the patient comfortably with their arms slightly flexed and their palm up with their whole forearm supported on a level surface at the level of the heart. So for our units, what we oftentimes will do is have the patient just bring up their knee a little bit, and they can prop their own elbow on their knee. The thing is also we want to have minimal patient contact. The arm above the heart will result in a low false reading. The arm below the heart level will result in a false high reading. So you want to be heart level. Improper cuff selection can result in a false high or a false low as well. The use of either arm, unless otherwise indicated, for example, handicapped, history of vascular surgery, mastectomy with lymph nodes, would indicate an arm on the opposite side of use. So we usually do RAS, right arm sitting, because that's where our operator stool is, on the right. So that's where we're taking our blood pressure, right arm sitting. Take the blood pressure on a bare arm, not over clothing, and you want to loosen any tight sleeves. You select the cuff size, you apply the cuff, you apply the completely deflated cuff on the patient's arm, support it at the level of the heart, and if the arm rests on the arm of the dental chair higher than the heart, again, it's going to be different than if it's directly at heart level. You place a portion of the cuff that contains the inflatable bladder directly over the brachial artery. And the cuff that we have has an arrow that lets you know where that brachial artery is, as far as this is where you place the cuff. The lower edge of the cuff should be placed 1 inch above the antecubical fossa. Fasten the cuff evenly and snugly. You adjust the position of the gauge or dial so that you can see it. It's facing you. Then you want to locate the radial pulse, and you palpate about 1 inch below the antecubical space to get the brachial artery pulse first. You hold your fingers on the pulse, okay? You want to mark that landmark, so either the patient can be holding the end of the stethoscope or you just know where you're going to be placing the end of the stethoscope. But you're going to then find the radial pulse, and you're going to inflate the blood pressure cuff until you no longer feel the radial pulse. Then you can close the valve and pump it to 10 to 20 millimeters of mercury higher than that. Now, what we tell our students at school is you find your radial pulse, you find your brachial pulse. I know where the end of the stethoscope is going to be. I place the end of the stethoscope there. I have the patient hold it for me. Then I've got my fingers on the radial pulse. I pump, 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 pump. I no longer feel the radial pulse. I then take my fingers, I say thank you, and I take my fingers and I now hold the end of the stethoscope, and I continue to pump 10 to 20 millimeters of mercury higher than that, and then I can start deflating the cuff. So we want you to be practicing this blood pressure on everybody you can practice with, because the more times you do it, the more familiar you will be with the sound of the blood pressure cuff, as well as the routine of feeling for the brachial pulse and feeling for the radial pulse. So you want to, after you no longer feel the radial pulse, you want to continue to pump 10, 20, sometimes 30 points beyond when you no longer feel that radial pulse. Again, you've cut off all the circulation of the patient, and that is the maximum inflation level. So we don't want to just willy-nilly pump everybody up to 180 millimeters. It's uncomfortable, and if my blood pressure was 110 for my systolic, that's way higher. You shouldn't be pumping me over 140. And if my blood pressure is 190 and you only pump me up to 180, you still haven't gotten it. So you're going to position the stethoscope. The earpieces should be angled forward. The bell of the diaphragm end should be placed with the light steady in complete contact with the skin. So you need to be the one holding that. You want to avoid contact with the cuff with the end of the stethoscope to avoid any extraneous sounds that can distract you. But you're going to deflate that cuff gradually. You release the airlock so that the dial drops very gradually and steadily, approximately 2 to 3 lines per second. And you listen for the first sound. The systolic, that first tap, tap. That's the systole. This is the beginning of the flow of blood past the cuff, and you note that number. And you continue to release the pressure slowly. The sound will continue, first becoming louder, then diminishing, then becoming muffled, and then finally disappearing. So you note the number on the dial where that last distinct tap was heard, and that's the number of the diastolic pressure. So you're going to release that, or write that down. You release further, maybe about 10 points until all the sounds cease, and then once that happens, you deflate the cuff, take the cuff off. You let the rest of the air out rapidly. You want to wait for about 30 seconds before inflating the cuff again, and you repeat it. And then what you're going to do is do an average of the two. So every new patient coming through the clinic, every recare patient, whether you've seen them 3 months ago or whatever, you're going to take the blood pressure twice on that first visit. If things are within normal limits, you're only taking it once thereafter. Refer to your clinic manual for the clinic parameters. Blood pressures are written as a fraction, so 120/80, for example. And that is considered pre-hypertension now. High blood pressure, hypertension, is a serious condition. It's a silent killer. 1 out of 3 individuals in America have high blood pressure and don't know it. High blood pressure is considered anything over 140/90 and is associated with cardiovascular diseases, strokes, kidney failure, premature death, Contributing factors to hypertension include smoking, stress, obesity, alcohol. And information about the patient's blood pressure is essential during dental and dental hygiene procedures. Blood pressure readings most usually are recorded with the medical history and other assessment data. There is something called white coat syndrome or white coat hypertension. I have that. And it's more commonly in the elderly. I resent that statement. And reported as frequently among centenarians. So the older you are, the more white coat syndrome you're likely to have. Readings taken at the start of the appointment can be significantly higher than those taken at the end of the appointment. So you want to establish a baseline reading and determine the need for patient referral. And I can't tell you over the years how many times patients have called me back saying, thank you, I went to my doctor, I'm now on blood pressure medication, and I just thank you. All right, so you can see that the clinician is holding the end of the stethoscope, and the forearm is properly supported. It's at heart level. This happens to be on and I'm pointing to it, and you can't see it, on an armrest. Right? You don't put it on your leg. It can be on the patient's leg, but not on your leg. Proper placement of the earpieces, all right, and improper ones, they should be angled towards the inside of your ear. This is just illustrating the correct stethoscope end piece placement. Good contact with the skin, but it looks like the arm is resting, the patient arm is resting on the clinician's thigh, so that is a major no-no. High blood pressure is a serious condition, so we take this seriously. Have your clinic policy manual available with you in clinic so you can refer to it if your patient has blood pressure out of the normal range and you're thinking, do I need a medical consult? Can I continue my care with them today? What do I need to do? It outlines all of that. So for follow-up, we need to advise the patient and refer the patient. I did have one patient that I took a blood pressure on, a young African-American male. He had extremely high blood pressure, and the doctor, I informed the doctor when he came in to do the exam, and the patient said, well, I'll take care of it when I get back from vacation, maybe in the next couple of months. And lo and behold, my doctor looked at the blood pressure readings and said, you don't understand. No, you need to do this before you go on vacation. And he did, and he was one of the ones that called back and said my doctor was really horrified at how high his blood pressure had gotten since he had seen him last. So even though it seems like a little thing that we do for our patients, it can really be life-changing for them. But we're taking vital signs in clinic all the time on all of our patients, and I hope that this is something that you continue to do in private practice, even if your practice isn't doing it. Start taking blood pressures on them. Start with just blood pressures. I've taken blood pressure on every patient since the day I graduated in 1981. That was, and as well as doing oral cancer exams. That's what I took away from my education. You have to pick and choose what you want to do, because when you have a 3-hour appointment and they are expecting you to whittle it down to 45 to 50 minutes, sometimes you just can't do it all. So you need to figure out what is important for you. But the criteria is to recheck within 1 year if things are within normal limits. Best practice is to recheck it at every visit, and that's what we do. That's what we teach. Our clinic policy is to check it at every visit. Usual practice is at every re-care. And honestly, unless I was giving local anesthesia or doing something out of the ordinary, I was not taking blood pressure each and every visit. If I was seeing a patient 5 times to continue to deliver care, I would take it at their first appointment, and if things seemed okay and I wasn't needing to administer local anesthesia, I didn't take it every time. Lifestyle modifications you can always talk to your patient about. And again, nothing is done without documentation. We need to carefully document our medical history. We need to document the vital signs that we took. And if anesthesia is included, especially, we need to be taking these vital signs. So we need to be able to tell our patients why we are taking blood pressure and the importance of blood pressure on their overall health, and encourage regular continuing care for our patients, and encourage healthy lifestyle, tobacco cessation, exercise, that type of thing. All right, so that is the end of our vital signs.